you so much for joining us today for what is our first ever EMEA Health Trust event. And I'm delighted that you could join me, and we've got an exciting hour ahead of us. I think perhaps one of the developments that's meant the most to me in my 4 decades, yes, I really am that old, in the healthcare business has been this increasing recognition of the important role that people with lived experience, patient champions, patient advocates, must play in every single part of the healthcare system. That's from research and development through to clinical practice, through to government policy. And that's been one of the great things we've seen growing and growing and growing, as I say, over recent years. Now, as we examined the findings of our 2025 Trust Barometer Special Report on Health and Trust, we began to see over a number of different data points that this group of people may have an even bigger role to play as we will find our way through what is an increasingly complex and in many ways distrusting health landscape. So what we're going to do today is I'm going to take you through the findings of the report, the ones that we have highlighted this subject for us. And then I'm delighted to say we have got a wonderful group of speakers who will join me for a panel discussion. And then hopefully after that, we'll have time for a Q&A. And please do drop your questions throughout the presentation and the panel discussion into the Q&A box on your screen. So without further ado, let me get into the data. My name's Carolyn. I am the head of the health sector at Edelman across Europe, Middle East and Africa. And as I say, this is the 4th year of our Health Trust Special Report. So if we can go into the next slide, please. And the next one. Thank you. We do this study across 16 countries, and 5 of those are in this region. That's France, Germany, UK, United Arab Emirates, and South Africa. And we survey just over 1,000 people in each of those markets. And this is a general population online study. So it's a broad swathe across the general public. And this study went into the field in March of this year. So it's pretty fresh and new data. Now, as I say, if we can go to the next slide, over the years we've been doing this study, we've identified a number of different trends. And some of these are really what's led us to this point that we're going to talk about today. The first of these has been the dispersal of authority. Right back when we started doing our big trust barometer 25 years ago, authority really rested with experts. But over the years, it's moved and shifted, and now it's more dispersed, as I say, and with peer groups. So we ask ourselves, now we're at a point where friends and family are as trusted as experts and scientists. Who can people trust when it comes to finding credible health information? People's view of health is now multidimensional. It's not just about physical health. People want to be healthy in terms of their mental health, but also environmental health, social health too. So how has that affected who we look to guide us when it comes to our personal health decisions? We've also seen over the last 25 years that trust is increasingly local. It's increasingly you trust the people close to you. So in a situation where we are now, where you'll see from the data that my doctor is more than twice as influential when it comes to public health opinions than global health authorities, who else has got influence in that sphere? And finally, we've seen trusted communities come very much to the forefront of people's trust and influence. So how can those communities retain trust, and how can some of those expert groups who may have fallen down the wayside a little bit regain trust? And that's something we'll talk about over the next 20 minutes or so. Now, on the next slide, we look at 4 main institutions of society when it comes to our trust barometer. And on the next slide, you'll see that unfortunately, the picture is not very promising. We don't trust any of our main institutions. We don't trust business. We're neutral when it comes to business. We're neutral about NGOs, and we don't trust government, and we don't trust media. And these figures have all gone down since last year. Now, even more concerningly, on the next slide, you'll see that when it comes to societal leaders, the picture is even more depressing, because most people believe that societal leaders purposely mislead us on health matters. And you can see here those figures for business leaders, government leaders, and journalists. So it's not just, a lack of trust, it's concern that these people are actually lying to us. And on our next slide, this carries through to trust in the media. You saw journalists were not trusted in the previous slides. But trust in the media to report on health has absolutely collapsed over recent years. You can see here it's down 13 points globally since January 2019. And on the right-hand side of the slide, you can see the big falls in numbers across some of the key markets, including, as you can see here, Germany, the UK, and France. A real lack of trust in the media, particularly when it comes to health. And of course, we would suggest that this is probably a hangover from the COVID pandemic, but the picture isn't getting any brighter. And on this next slide, now this is actually, I have to say, this is from our big trust barometer of 28 markets that we do in January. But just to give you a bit more detail, you can see that fall in trust is across all of our news sources. The most trusted, and when we see the data, the dark blue box is always trusted. The teal, I think it is, box is neutral. The red is distrusted. You can see the most trusted source here is search engines, which of course is under our own control. Then traditional media, and right at the bottom of the list, social media. So going back to our specific health report, where does this leave us? Well, if we can click through to the next couple of slides, please, Jess. We've said in the beginning that experts used to be the big authorities, but as you can see on this slide, the person we trust the most to tell us about health is my doctor. Now, this isn't just any doctor. This is my doctor, my healthcare provider. But look here, close behind that is my friends and family. Now, of course, what's common about these is they're both local. They're both my doctor, my friends and family. And you can see in third place, even my CEO is in the neutral zone because, again, that's someone with proximity, somebody I know. We trust people close to us. Now, this dynamic also plays out, as you'll see on the next slide, when it comes to health influence. Again, at the top, you can see here my doctor, closely followed by my friends and family, but also medical science and health experts. My friends and family, equally influential over people's health decisions as medical scientists and health experts. And look what's just below that. People with similar health conditions. In other words, people with lived experience are patient champions. And just note here on the right-hand side of this slide that 18 to 34-year-old age group, much more influenced by what we would call non-institutional sources than older groups. Now, what could be going on here? Why are we seeing this dispersion of influence when it comes to health matters? Well, on the next slide, here's something that gives us a bit of the clue. I mentioned earlier the multidimensional nature of health, that it's not just physical, but mental, social, environmental. Well, this is possibly what's driving it, because when people are wanting to ask questions about the full gamut of their health, they may recognize that the doctor isn't perhaps the expert when it comes to social health or environmental health or even potentially mental health. And you can see here that 53% of people in our study said, I don't think if my healthcare provider is not completely qualified or only slightly qualified to take care of my full range of health issues, then I'll go to these other sources. And you see here at the top, 65% going to what we're calling those non-institutional sources, friends and family, online search, even social media, although there's a low level of trust in social media. And then that's followed by the institutional, and then those trusted communities, the sort of online communities and the patient groups. And when people are evaluating who is a legitimate authority when it comes to their health, well, you'll see on the next slide, it's not just a matter of what academic accolades they have. It's not just about those lovely shiny certificates with the gold braid that they have in the doctor's offices anymore. Yes, that's important for 72%, but look at these other figures. For 67%, it's personal experience with the health issue that they are experiencing. And who is this group? These are our patient champions, of course. Close behind that, people who have benefited from, who've given me good experience in the past, whose advice has been helpful to me previously. Now, when we ask people, what is it that these uncredentialed voices, and it's uncredentialed in the traditional, academic sense, what is it that these are providing that those institutional voices don't? Well, on the next slide, here's the real crunch here. Look at this, 68% of people described the patient advocacy community to a T. They said, these are people, this is what I get from these voices. I get knowledge of health issues that affect people like me. I get direct experience of my issue, and I get empathy for my situation. And on the next slide, you can see that this actually, we've broken this down by gender, by age, by income group, and by politics. These factors are consistent across nearly all of these demographics. At the top here, and regardless, it's empathy. Number 2, direct experience of my issue. Number 3, knowledge of health issues affecting people like me. So as you can see, that far and away points us in the direction of the patient advocacy community. Now, if we click through to the next section, adding to this sort of what we're calling a slight reconfiguration of health influence is the acceleration of young people's engagement with health information. The young people are creating effectively their own health ecosystem. And you can see here that first and foremost, this is identified by democratization. I have to say, and some of you would have heard me say this before, I find this slightly scary, this data point, because 35% of people who responded to our study said they thought that the average person who's done their own research can be just as knowledgeable on most health matters as doctors. And to those people, I say, please have a rethink and think about what it takes to be a doctor. Those 5 years of medical school and 2 years of training, whatever else, are not for naught. But you can see here, again, much stronger in that younger health group, that younger age group, 18 to 34-year-olds, 45% of them think they can know as much as a doctor, compared to just 23% of the older age group. Now, perhaps this confidence in their own ability is coming partly from the fact that, as we see on the next slide, young people are increasingly engaging with health information, and that's a good thing. This is a real positive thing. On a monthly or more basis, 2 in 3 of them are reading health media at its original source, or health media that's sent over social media. And an increasing number of young people are also getting independent media. So that's stuff created by podcasts and newsletters outside of newsrooms and so on. And it's not just consumption, but it's creation where this younger age group leads as well. On the next slide, you can see here, this 18 to 34-year-old age group are also the group most likely to share health-related news items, to post about their own health experiences for their online networks to see, and to share their personal opinions online too. And all of those figures have gone up over the last year. And perhaps it's no coincidence, as we see on the next slide, that young people are therefore also the most likely to make health decisions based on advice from people without formal medical degrees. And you can see here, that's 45% of people in the age 18 to 34-year-old group versus just 22% of the 55 plus age group. But unfortunately, this can come at a cost. On the next slide, we see that nearly 6 in 10 of our respondents regret a decision that they made based on health misinformation. And we all know what a huge problem health misinformation is in the health landscape today. And that's one of the reasons why we came up with this idea that actually the patient advocacy community are so important in combating this. And on the right-hand side of this slide, you can see where that bad information came from. And interestingly, first and foremost here is user-generated content. So user-created content platforms was the primary source of misinformation, closely followed by independent content creators. And then in third place, friends and family. Now that's despite those friends and family being one of the most trusted sources that we came through on the earlier slides. So, having won this role in the healthcare ecosystem, our patient champions have that empathy, that direct experience. They all of the qualities that people have said they trust and are influenced by sit in this community. How can the patient advocacy group retain this and perhaps even extend this influence? And are there lessons to be learned for other healthcare stakeholders? Well, we've highlighted 5 main imperatives, if you like, to holding and retaining health influence. And I'll take you through these now. First and foremost, it's relevance, that personal relevance. For me to see you as a legitimate health expert, it's important that you understand what people like me need and want. 66% of people said that. And this, of course, is an area, again, where the patient advocacy community rates highly. Secondly, it's frequency of communications. The more times people see information, the more believable it becomes. And we've seen this time and again in our previous studies across a whole range of topics. But look at this, notably, when it comes to health authorities, be that local, national, or global, they're much more believable compared to social media and podcasts. Look at the difference in the bars here. But also, they become more believable with repeated exposure. So that need for constant communication is really highlighted here. Thirdly, we touched on this very strongly, empathy and accessibility are absolutely key. People who go to those uncredentialed voices are doing so for two primary reasons: to find empathy, and because those voices have direct experience with their issues. And again, those were the top two results across age, gender, income, political affiliation, etc. Fourth, it's relatability. And this is especially so for that younger age group, those 18 to 34-year-olds. If we want to support that younger generation and help them make sensible decisions about their health, we've got to leverage relatable sources of health information, those that are personal and approachable on a human level. Now, whether that means, as you can see here, people online with similar health conditions as me, or whether it's, as you see here, interestingly, individual content creators, but with medical training. And finally, you won't be surprised to hear this because I think I belabored this a little bit earlier on, it's proximity. Trust is local. The importance of going local to build trust and strengthen influence and avoid polarization cannot be overstated. And you can see on this slide, which across the political spectrum, you can see all of those blue bars on the right-hand side, whether we're left, right, or center affiliated in our politics, we all agree that we trust my doctor and local health authorities. Where that polarization starts to come in, you can see that on the left-hand side, is when it comes to global leaders. There you see difference between who trusts local leaders of health NGOs versus who trusts and distrusts health CEOs. So when we look to elevate voices that are closer to people in our communications and think, we must think about that local proximity. That's so important. So I will finish with a couple of conclusions here, and then I'll open this up to the panel. So what all of this data suggests to us, and obviously we'll get some expert insight from the panel in a moment, is I feel that the role of the patient champion is stronger and more necessary today than perhaps it's ever been. Because we see that traditional scientific and medical authorities don't have the monopoly on influence anymore. And there's a whole range of new credentials that we've just highlighted today, including those most commonly found within the patient advocacy community, which hold sway now. To the public, personal experience of a health issue is just as important and compelling as, clinical trials, certificates on the wall, etc. And I think we always used to feel in the sort of healthcare business a bit as if the personal anecdote was kind of the antithesis of scientific evidence. But if we're learning anything, it's that actually personal experience has just as much value, and that's an important thing to bring into our conversation. Young people, we've seen just from the slides I've been through, are consuming and creating healthcare content at a stunning rate. And if other people want to get a voice within that community, they're going to have to ramp up the frequency of their communication and make sure they're showing up in the right places. And last but not least, as it says here, you have to activate those trusted networks. Providers are most trusted, my doctor, but if people don't get what they need from their doctor, they're going to turn to friends, family, and people with similar health issues. So we've got to make sure that those voices are able to be accessed easily, able to be heard, and able to be reached. Okay, so I went through that at a bit of a pace, but I'm hoping that the key points have stuck, and I'll find out in a moment when I talk to the panel. So let me, without further ado, I'd like to introduce the three wonderful people who are going to finish this event off with me today. And I am deeply indebted to all of them because they're all incredibly busy. They're also women, so they're multitasking every second of their days. And I'm delighted they can be here. I'm joined today by Sarah Kline, who is the CEO and co-founder of United for Global Mental Health, by Vanessa Pott, who is the head of global patient engagement at Boehringer Ingelheim, and by Anca Toma, who is the executive director of the European Patients Forum. And all three of these women have direct experience of all of the things we've been talking about this afternoon. And I'd like to just sort of open up by asking each of them what their sort of primary reaction is to the data that we've just gone through. And Sarah, if it's okay, I'll start with you. What's your sort of first response to the data that we've just gone through?
Thank you, Carolyn. Thank you for having me. Yes, I'm the CEO and co-founder of United for Global Mental Health, which is a mental health advocacy organization working globally to get mental health up the political agenda. But I'm also, we are the Secretariat for the Global Mental Health Action Network, which has 6,500 members in 170 countries. So I'll try and bring in the truly global experience. And we've actually met, I'm at the World Health Assembly this week. And I think almost all of the 16 countries that are represented in this survey have been speaking on mental health, and we've been meeting with them, so can speak to some of those conversations. I mean, I think the first point to be clear on is that when we talk about health in this context, I think there's quite a spectrum between wellness and well-being and health and severe health conditions. So I think it's important to be aware that I'm not surprised to hear that young people feel that they are able to navigate advice for their well-being, to think about basic lifestyle choices around diet or exercise. I think we've always done that. And for those of us who are quite naive, smoking or drinking when you're 16, 17, 18 is not exactly unheard of. I think that's a very different thing to then seeking information for example, a severe mental health condition, for something like cancer or heart disease. And I wonder whether we need to be really focusing down on where the spectrum is within this discussion on health. In terms of then where we're finding information and why that matters, it is important to understand why people do or don't trust the medical community and the wider health community. If you live with a mental health condition, you may have experienced, for example, the concept of substituted decision making versus supported decision making. In other words, you may be told if you're experiencing a period of mental ill health, you cannot decide what is best for you. A physician will do that for you. That is a very hard message to hear and not one that people necessarily feel comfortable with. It's likely to put them off going to a mental health professional. The other thing to be aware of is even in the countries that you're talking about, and certainly more generally, it's very hard to get access to professional health care. So I think the average young person in the UK is waiting up to 6 months just to see a mental health professional. So there are various factors behind why these figures are coming. But I think the important thing looking forward is to make sure if people are going to sources other than a doctor or a recognized health professional, they do need to be regulated. So what we're seeing on the internet, or take this quiz, or maybe you're bipolar, come here and enjoy some level of therapy. These things should be much better regulated so that there is regulation around people identifying or navigating this material. And secondly, that this suggests that we need really carefully to think about health literacy amongst the general public. So what is it that we're giving by way of public health messages, such that if you cannot get access to a health professional, you're getting the right messages. So we saw during COVID a lot of misinformation. We need to really think about the ongoing public health information. I hope that's useful.
That's great. Thank you, Sarah. And yes, I hear you loud and clear. And health literacy is something that is a subject I know we all keep coming back to, and is touted as, perhaps the most powerful weapon against misinformation. Vanessa, I'm going to come to you next. Any immediate reactions or responses to the point Sarah's made?
Well, yes, to the points that Sarah made, but also more broadly on the data that you presented, Carolyn. And I just wanted to call out two things that really stuck with me. One was the comment you made about maybe, and I remember, I don't know, maybe 10, 15 years ago, or even today, there's always this sort of, oh, well, yeah, I should consult a Dr. Google, or, and you said, we used to think that there's some kind of like lesser worthiness. And now we're seeing that actually trust levels are going up, independently of whether it's based on scientific evidence or not. And I think that's a fact that we must not ignore. And it doesn't need to be necessarily a bad thing. It's just important to know that there's still a difference between having trusted information coming from non-scientific sources, which I think is where the patient advocate plays a huge role, the patient advocacy organization, and trusted as a trusted health provider of trusted health information, versus then the misinformation that you can find in other platforms. And this is, I think, a great distinction that your data quite nicely portrays. The second point, of course, for us, a pharmaceutical company, I think there's no secret here that, of course, trust levels in pharmaceutical companies are not necessarily that high, and we understand that, and that's also based on some historic missteps, maybe, and some concerns around transparency, etc. That I know today we are all working hard to address, and certainly at Boehringer Ingelheim, I can speak for our own company. We are really looking at how can we make sure that scientific information is understood, and that we are working with patient advocates along every step of the way, not just when it comes to information about the drugs and treatments that we provide, but also really looking at understanding where would patients go for trusted information, so that we can also make sure that we are not just expecting that information that we would provide, let's say, from a more scientific medical setting, is also then understood and helps, really in informed treatment decision making by patients and their caregivers. And I think that there's some really interesting lessons here, what you were showing on the screen, so we can go into that a little bit further.
Great. Terrific. Thank you, Vanessa. And yes, that ensuring the accessibility of scientific information is so key. And I mean, we haven't shown today all of the data from the study, obviously, but that is also one of the things that comes up year and year as being a barrier that stops people maintaining their health as well as they might like to, is being able to access and understand information. Anca, I'm going to come to you. What are your first thoughts on the barrage of data that I have thrust upon you this afternoon?
Well, I have seen some of the data before. Thank you for the invitation, Carolyn, and it's really nice to be part of this panel. Look, I love the conclusion. Indeed, patient advocates are bastions of trust. It's quite clear from your data that trust in peers is increasing. I think it reflects to some extent also the growing maturity of patient advocacy and of patient organizations. Now, the European Patients Forum, we are an umbrella organization of umbrella organizations, and I'm looking at it from a little bit, I try to take a helicopter view, but this data to me is very, very human. And what was very interesting in this data for me was that in a lot of the categories, the political divide is not so stark as it may seem from reading the news. In the end, we're all the same, and we kind of, we're all human, we're all made of flesh and bones, and we are looking to more or less the same sources of information for trusted health data, for trusted health information. Now, both Sarah and Vanessa said things that I agree with. The last one that I noted down here is the importance of lay language. And that's where indeed patient advocates have a very important role to play in translating complex stuff into language and ideas that everybody can grasp even without a scientific background. What I also see is a sort of validation of what we've been saying for some time about the role of patient advocates and about the role of organized patients, of patient organizations, and of their representatives in aggregating that community view and providing information coming from their communities towards the public, towards decision makers, towards public authorities. I see that as a public service. We see that as a public service. And your study tells me that it is a huge responsibility on us as patient organizations to maintain that level of to increase that level of trust and of representativeness and of legitimacy, so that it remains a public service, and it remains it's put at the service of our constituencies. And that brings me to my inevitable point, which I make all the time. It is about empowering and supporting and elevating the voice of patient communities.
Yeah, absolutely. Thank you. And I don't think there is ever a time when it's not appropriate to make that point, Anca. So absolutely couldn't agree more. Now you've all spoken in slightly different ways about the responsibility that this level of trust that is being placed by the general population in the patient advocacy group. That is a bit of a responsibility. It is something that seems to be becoming increasingly important. How do you think the patient advocacy community can maintain that high level of trust? I mean, what are some of the tools and techniques or whatever it may be that you think are going to be important in maintaining that? Anca, you just, for example, talked about the importance of lay language, for example, and what do you see as some of the key things that the patient advocacy community has to do to maintain and hopefully even extend this level of trust?
I can comment on what we do as an umbrella organization that, in reality, we don't work directly with the patients that we strive to represent. What has been working really, really well for an organization like ours, which is made of members, is the sort of the governance, the internal democracy, and the checks and balances in how we make our positions, how we build our positions, how we build consensus, how we consult, and how we communicate both ways between the organization and its members. And I think that is a really important element that applies not to just an organization of organizations like ours, but also to patient support groups, organized patients advocacy groups that work directly with larger communities. I don't believe there is a substitute for that, because it allows us to be attuned to what the community needs, what the community perceives, but also to make the community, to alert it to areas that perhaps they haven't seen coming, but they have to be prepared for. So that's where the two-way communication comes into place. For me, that is the key to being credible.
Yeah, and Sarah, I mean, you mentioned at the outset, not just the United Global Mental Health role, but your role, the role in that broader organization. I mean, that's a lot of constituents to represent. How do you go about doing that?
That's a good question. So actually, here at the World Health Assembly, we have a number of representatives from the Global Mental Health Action Network, and they are the ones who are speaking to their governments and to authorities. And I think what we were hearing before is a couple of different things that they and their work, which is so important. So, for example, we have David here from Let's Unpack It in Barbados, able to talk to the experience of young people in the Caribbean and what they need by way of mental health support. The fact that suicide is still a crime in a number of countries, including in the Caribbean, and the need for regulation reforms, but also access to services and the context in which they're living, particularly with climate change and the impact that has on health services. We also have a colleague here from Teenagizer, which is a non-profit working with young people in Ukraine. So how do you deliver mental health support virtually? How do you deliver online or on telephones, etc.? I think what we see with our colleagues working in different countries is their ability to engage with their governments and to have influence and be credible is because they are already representing large numbers of people, and they are already providing, in some cases, their own care and support. As I said, Teenagizer is one, hashtag mental health PH in the Philippines is another. They actually offer support as well as policy advice or policy direction, and they encourage a health literacy. One of our colleagues, Taskin in Pakistan, has very effective videos and short, accessible kind of information online that you can see to try and understand and destigmatize mental health. But they've also led the suicide decriminalization work, and they are the ones who are voicing the experience of people with lived experience of mental health conditions. So I think all of those things matter. Ultimately, to your earlier point, it's about proximity. So ultimately, this is about community-based care. And I think what I found most encouraging was that this emphasis on the family doctor, the local support. Most health conditions can be dealt with at a primary healthcare level. So it's really important to hear that people are saying that that investment is essential. The people who aren't being held, where patient advocacy is not necessarily possible, are the people who are held in institutions, mental health institutions, sometimes for years at a time. So those are the people that we have to bear in mind and we have to speak for, and they may or may not be able to speak for themselves. So we did include a colleague from Cultivation for Users Hope in Liberia, who spoke about being shackled for a year while he was in theory being treated for his mental health condition. Shackling is not uncommon in the context of mental health. If you do not have full rights as a citizen, you are unlikely to be heard. And it's incredibly important, but that's also part of what we do, is speak for those who do not have currently a voice.
Yes.
Carolyn, can I ask a question directly to Sarah?
Yeah.
Yeah, so just because it was a thought that was running through my head throughout the presentation, because the topic that we are increasingly looking at within our company, but more broadly pharmaceuticals, is patient experience data. And how do you actually bring all of these rich experiences, and some of them as horrid as you just described, Sarah, how do you actually bring that into robust data to then help shape, like you were just describing, policy, for example? But also more broadly than that, we know that patient experience data can play a role also in the regulatory decision making, in HTA and other reimbursement decisions around the world. And you know, I'm just curious, with all of this rich experience from the ground, how are you seeing that? Because I think it would be kind of the translation of what we've been seeing here in the trust data, is turning that trusted source of information into actual evidence and using that to change outcomes for people living with conditions around the world.
Yeah, I think it's a really good question because, as I said, sometimes people, well, I can only speak to mental health, that's the area that we work in, but I think sometimes people with mental health conditions are not consulted and therefore they're not part of data sets. So if you look at the main data set that is used internationally, that's the Mental Health Atlas of the WHO. We're meeting with them today, and the new version will come out in July. That's voluntarily collected data according to what governments themselves say. So it's not necessarily going to be the same as what you would have with a patient advocacy group or a group of lived experience. What we have tended to do is to work through partners to try and get information through them, and we produce reports on that basis. We were also part of the Lancet Commission on Ending Stigma and Discrimination in Mental Health, which had a survey of people across, I think, 50 countries in multiple languages in order to directly understand what people living with a mental health condition experienced. And they said that the stigma that they experience because of their mental health can be worse than the experience they have of the condition itself. So it is possible to do survey data amongst people living with mental health conditions. I was only cautioning that there are sometimes people who are left out because they are not treated as full citizens and they are incarcerated, often against their will. But overall, I think that the voices of people with mental health conditions or living with the mental health experiences are increasing. I think they're being heard. One of the things which is most encouraging from what we've heard in the last few days is that countries as diverse as China, India, South Africa, Brazil, Mexico, Japan have all stood up at events that we've been working with them on and have explained what they are doing to try and champion more progress on mental health. I think the unspoken way of indicating a country's health position on mental health is suicide rates. So suicide rates are perhaps the most stark indication of a mental health condition, of the state of mental health in a country. And it's very encouraging where we've seen countries such as Guyana or Sri Lanka, which had very high suicide rates, really dig into why those people are struggling with their mental health and what it is. So one of the issues one needs to do is not just a survey in general terms, but actually take an epidemiological view, if you like, and look at why is this epidemic happening and what are the causes behind this epidemic. And sometimes, particularly in emergency settings, it could be suicides for children as young as under 10 because they are living in the most terrible physical health conditions. But in other cases, it might be farmers in India who have access to high strength pesticides. It might be young people in South Korea who will feel under tremendous pressure because of educational attainment goals. So some of this is about trying to drill into the different communities and what are they experiencing. I hope that helps answer the question, Vanessa.
Yeah, thank you, and very inspiring, if I can say it like that. Yeah.
Now I'm gonna switch us to the Q&A because, and I've done a few of these type of events, people, and there's an unprecedented number of questions coming in. So we are clearly, you know, striking a chord with people. This one, I'm gonna pose this to you, Anca, first, because I know the EPF works with a number of different kind of partners across all, you know, dimensions of the healthcare system. Now, somebody has said here, sorry, I've lost my question. Okay, what best practices exist for fostering transparent and ethical collaborations between patient advocacy groups and other stakeholders, such as pharmaceutical companies and policymakers, to ensure patient interests remain central? If you want to take a first stab at that, Anca, and then maybe I'm sure, Vanessa, you might want to have a comment on that too.
Well, I mean, I don't have to look very far because we're trying to set these standards across our communities. The EPF has a framework for collaboration with the pharmaceutical industry or with industry more in general, and we exercise full transparency on how we work with partners, what the limits are, what you know, the sort of things that we don't do, and we make essentially all of our work is public. It's in the public domain, and actually it is also, you know, that level of transparency is also one of our membership criteria. So we are looking at the sort of organized communities that are also organized, and we have capacity building on maintaining those standards as well. So we're looking at organized communities that are operating on full transparency basis. We feel as a community that transparency is the most important basis of credibility, independence, and trust. And then we just have to walk the talk. To walk the talk. Yes, to walk the talk. Yeah.
Right, Vanessa.
Yeah, just to add, because Anca already spoke about the transparency and making public the collaboration as such, which is what we do. We have contracts in place, so there's always that side of things. But the other aspect that I wanted to bring here in terms of best practices is, I think it's also part of ethical considerations, because I think the question was around really what are best practices for ethical collaborations. And I think an important part of that is also collaborating at the right time and making sure that it's not tokenistic. I think that is also an ethical obligation of the pharmaceutical companies, that when we engage with patient advocates, for example, that we engage with a clear purpose, and that it's at the right time, meaning that we're not just trying to say, well, we spoke to some patients. No, we have to be able to think in advance, what is it that we are still able to address? What can we actually change? How could the information that we receive actually change whatever it is that we're talking about? For example, if we find out something new about real lived experience that would shape significantly the development, let's say in our case, of a new product, are we able to take that on board or not? Because I think that's the starting point for all of these considerations. It's not just that we have a clear framework, that there are contracts, et cetera, and transparency, but also the when and how do you engage with whom, to what effect. And I feel that we as patient engagement experts within our companies, we play a huge role in ensuring that that is the case indeed.
Right. Sarah, I'm going to put this one to you. Somebody has asked, given the erosion of trust in traditional health institutions and the rise of misinformation, how can patient advocacy groups position themselves effectively as credible sources of information? And are there any strategies that you've used or seen that have proven successful in countering misinformation while maintaining trust? So how is it, how can patient advocacy groups go about ensuring they are seen as credible sources of information?
Thank you. I think that's really important. Just to go back for a minute to the best practice on engagement, if that's okay. We've been working on a pharmaceutical company engagement principles as the Global Mental Health Action Network in order to help guide partners, because there is, frankly, a lack of money in mental health space. There's a lack of money always for civil society. So it's important to have some very transparent guidance in place, and appreciate very much what Vanessa and Anca have said. The convention in the mental health community is not to take money from pharmaceutical industry, and we also abide by that, as does WHO in that context around mental health specifically. But as Vanessa said, ultimately this is about transparency and about being aware of what each other are working on and why. I think the reason is that's partly historic, but it's also partly today, where if you still have a context in which substituted decision making is taking place, that means people that other than the patient are making decisions on pharmaceutical use or around other treatment use, and that is, if you like, uncomfortable. I'd say quite a bit more than that for people with a mental health condition. So it's not really best practice. So that's why there's a bit of tension, I think, perhaps there in that way that we have to be very aware of. And we would always advocate for supported decision making. In terms of credible sources of information and countering misinformation, I think part of it, frankly, is simplicity about what mental health conditions are and what they are not, what severe mental health, ill health looks like versus normal episodic periods, perhaps, of anxiety, depression. Not everyone will live with a severe mental health condition for their whole life, but many people will experience a period of anxiety or depression for which they may want to seek help either from friends or family. So I think it's really important to be as transparent but also as simple as possible in explaining perhaps complicated terms or terms that are not well understood within the general public. I think what we've seen in terms of maintenance of trust perhaps is as we've seen before, which is where you have often people who are medical doctors but can speak in simple and clear language and can speak with empathy themselves. So some of the best people that we've seen as communicators are doctors who are able to be open about their own health conditions. So they come from the perspective not just of a doctor, but a human being. And some of those that have been the most effective, for example, the wounded healer is someone who's done a lot of communication in the UK, is able to say, I have my own lived experience of depression, but I am also someone who is able to identify and treat for mental health conditions. And I think that's something that we need to really appreciate with healthcare professionals, is they are human. They also need support for their own health. We saw that particularly during COVID. And it's quite important that they are able to draw on their lived experience where appropriate in for conversation. Thanks.
Yes, it's interesting you say, actually, because one of the questions that came out was who does my doctor trust for information, which we won't get into now because we don't have the data on that yet, but perhaps we will next year. I want to touch on something else which has come up actually in a couple of questions, and Anca, I'll probably come to you first on this one. One question was, how can we guide more patients towards patient advocacy groups and organisations? This person has said that they believe that currently groups only attract around 20% of patients in their chosen condition. And then another question was, could we do more social prescribing, which is apparently something that has started in Canada, and Sarah's nodding, so I'm glad that's right, which is directing more patients to groups to avoid misinformation and achieve better collaboration across stakeholders. So Anca, do you have some thoughts about how we get more people to come to patient advocacy groups like yours that, which can provide them with credible, accurate information?
I have some ideas. Of course, I didn't necessarily prepare for this question, but I've seen it in the chat, so I've been thinking about it a bit for the last few minutes. Look, I think there is a need for, going back to the ethical relationships. I don't want to give an idea that everything is rosy. There are still instances of tokenism. There are still power imbalances between patient organizations and other stakeholders in the system, and not just necessarily the industry. And patients are still not sufficiently included. Which brings me to my view on this question. There is a need for patient organizations to be more visible. I do not believe, and it is not part of our ethos, that every patient should be an advocate or that every patient should get organized. That is where autonomy comes into place. People should be empowered to be patient advocates or not, as they see their own needs. But there is a need for patients who are looking for peer support to have access to patient organizations that are visible, that are known, that are easy to find. And when we go to the local level, that is very, very difficult to achieve without some significant, or not even significant, some minimum resources to be able to promote the existence of patient organizations. So what is needed, I think, is more visibility, and that requires resources and public support to the public service that patient organizations provide and to the value that they bring to their community, which is, it can be quantified, it has been in some cases, but more often is just on the human level and is just invaluable. On social prescribing, I think this kind of comes naturally to what I said. Social prescribing could be an additional tool for getting people to patient organizations, but that requires healthcare practitioner awareness of patient organizations. And I think that is still work in progress.
Okay. Vanessa, I'm going to ask you about, I wonder if this is a role where other stakeholders can support patient advocacy groups.
Yeah, and I mean, in some instances, we also work together. So I know specifically of a project where we were involved with a number of patient organizations also in signposting, basically developing handouts, leaflets that would be handed out through the physician at the time of prescribing one of our products, for example, and would also then signpost to the patient organizations that are active in this disease area, so that the patient also knows where to turn for additional advice and support. And that was something that was actually requested or suggested by the patient organizations, saying that, why not also use that as a channel for getting patients involved, individuals involved with the patient advocacy group, or at least not, I mean, to Anca's point, not as organized advocates, but at least as consumers of the information and the support that the patient organizations can provide. I think the other aspect is going back to the data that you presented, Carolyn. There's, of course, also, you spoke specifically about the youth health ecosystem and younger generations, and as such, there is no one patient, is there? So I think it's also okay and legitimate and actually necessary that not everyone will be organized in patient organizations or turn there first. I think there are also many other community-based organizations, be that of faith, be that of other characteristics, where people naturally feel these are trusted sources of information that may also play a role in providing trusted health information as well. So I think the term advocate can actually also be seen quite broadly, and is not just patient organization representative. We also, as a company, are looking to also broaden out some of our activities when it comes to, for example, including people from diverse backgrounds in clinical research. We know that that historically has been really quite lacking, and therefore, the data that ultimately decides and leads up to the decision of the approval of a new drug sometimes is quite limited in terms of who it actually represents, doesn't fully represent the spectrum of the future patient population. And so trying to make some inroads there by going more into minority groups, etc., also to try and raise some awareness of clinical research there. Just to add some thoughts on this point.
Great, thank you. Sarah, we've had a couple. We clearly have an audience beyond EMEA. We clearly have an audience in North America because we've had Canadians talking about social prescribing. We've also got somebody saying, we wonder, and I'm going to come to you first, Sarah, because of where you currently are in the sort of thick of the health ecosystem. Whether you have any thoughts on how the recent actions in the US regarding defunding of medical research and organizations, how might that impact trust in global and national health authorities?
Thank you. Yes, I'm in Geneva at the moment at the World Health Assembly. So health ministers from the majority of countries are here. The US is not here. They did a video message. In answer to your question, there was obviously the immediate cutting off of funding to the World Health Assembly by the US government, which has a significant impact. But I think we need to understand that this is a context in which a lot of bilateral governments are cutting foreign aid. It is not just the US, so there is cuts that are taking place amongst the European countries that also are impacting access to services. But some of the biggest cuts are obviously coming from the US, particularly for USAID. In service delivery, it is most definitely impacting the access to services for people with mental health conditions, and particularly people living with HIV or TB, for example, who may have been accessing mental health support as part of an HIV or TB program. I think the longer term impact at the moment, I think we don't yet know fully. The US government has been one of the biggest funders of mental health research behind the likes of Wellcome. And that is a significant change if they are no longer going to invest in that research. We urgently need more and more research in mental health. There is always more that we could learn. So I think this is still to be fully understood, but certainly it is having an impact. It has an impact that the US is not here and involved in conversations about health in the same way. We're going into a UN high-level meeting on non-communicable disease and mental health in September. It will be interesting to see how countries approach that, but we have seen, as I said, the likes of India, China, South Africa, Brazil, Japan, France, South Korea, all stepping up and saying they are committed to global health and including mental health, and that we have to take as encouraging.
That is indeed encouraging, and I'm glad we've managed to introduce an optimistic note in there. We've literally got 2 minutes left, so I'd like to give the panel just an opportunity to maybe in a couple of sentences sort of maybe summarize their key takeaway, their key conclusion from everything we've discussed this afternoon. Vanessa, can I ask you to go first?
I'll just be quick and brief and say that this data is just another encouragement for our work that we do in patient engagement, working closely with the patient community, making sure that we now go a little bit deeper based on the findings. I think very interestingly for me was the point around youth health ecosystem, something to consider, and that I will discuss with my team on Monday when we have our next team meeting.
Great, I'd love to see that immediate action. Anca, for you, what's
my main takeaway is about the need to match the trust place in peers, essentially in peers, and I think that the key term in patient advocate is not patient, it's advocate actually. In this context, I think it's necessary to match that trust with community engagement, patient organization engagement, and involvement in healthcare policy decisions and healthcare organizations, healthcare organization decisions.
great. And Sarah, finally over to you live from Geneva.
Thank you. As I said, I think I'm very encouraged by the emphasis on community-based care, and that most health support, particularly mental health support, from my perspective, can be given in the community. I think that's really encouraging to see that coming across. And secondly, the point about empathy, I think that's really important in the context of mental health, where you see huge amounts of stigma. So the demand for empathy and understanding about the full spectrum of people's mental, physical health, social, environmental health is key. So I guess I would end with the phrase, nothing about us without us. Thank you.
That's a brilliant note to end on. My huge thanks to Sarah, to Anca, and to Vanessa. I am hugely grateful for the time you've given. I know how valuable your time is. I've really enjoyed the conversation from the comments I've seen coming in, so has everybody else. So thank you so much, and thank you to everyone for tuning in, and we'll hope to see you again soon. Thank you very much indeed.
It's been a pleasure. Bye.
Thank you.